Nothing like a little enactment to wake up everybody after a really nice lunch like that. So here's where we are. We now have the opportunity to have that conversation with the parents of the 3-year-old who died in the organization, where you know all the facts that need to be known in terms of the care in that case. There was a pretty obvious mistake that was made with the amoxicillin. In fact, don't be surprised if the family didn't look it up and realize, wow, that seems like a lot more than what Charlie should have gotten. That's the child's name was Charlie. The parents are Scott and Sarah, and those are the ones that and they've already signed the consent to have this conversation, so you would have a big comfort level in going up there, because again, no matter how you might misspeak or words aren't quite perfect to come out, this is a confidential conversation anyway. And going back again, the big 3, can't say this too many times, hopefully by the end of the 4th workshop, Kate, people will be able to actually give this talk. In fact, I know Jack will be able to, because he's heard it a couple of times. But this is the piece where it really is a process, not an event. And this is a good opportunity to share everything you know with this couple who's had the tragedy of losing their little one. And so, as we've done at the other workshops, again, you know the facts of the case. This is where we want you to huddle up at your table and talk amongst yourselves with these questions. And think about, in this scenario, unlike the one we'll do a little bit later on, what are the goals of this conversation? You are responding a month after the death of the child. So that's just an important piece of fact to know. A month has gone by, and again, this is that opportunity to have that at your table. You want to, and this is a really important part, and we saw that when we had Mike and Lisa up here earlier, is in your organization, who would you imagine be the best people to now have this conversation? So some of you may need to play that role of whoever that is. Feel free to step out of your comfort zone and do that. Probably you can already, going through your head, think of a lot of questions, right, that you'd be asked if you went in to meet with them. And as we did at the first 2 workshops as well, think about what emotions you anticipate and how you would name and validate them. What did we learn in the first 2 workshops about emotions that you guys remember? So acknowledge it. If you see it, name it, right? What other really, I think, really good pieces of advice came out related to emotions? Don't negate them. In other words, making it very clear that any emotion they have is an okay emotion to have. It's behaviors we don't want them to have, but any emotion is okay to have. And it is important to not negate them, to validate them, and as we kind of heard, and it's really hard, not get defensive. In a case like this, there might be a tendency to do that since you know the care was okay or that the mistake didn't cause the harm. It's just to kind of be mindful of that. It's about them. It's not about us when we have that conversation. What are you going to say to the patient and family? I'm going to walk around to the different tables as you talk about it. I'm going to have Jen do that too. One of the questions that may come up is, can you think of a situation where a little bit of service recovery, might be useful here? And that's why I asked Jen about that in this particular case. What are you going to share? And then who's going to continue to respond? And we brought this up at previous workshops. When is and this may not be completely consistent, Kate, with the law, but in general, when is the candor conversation over? Or conversations, should I say. When are they over? Well, what's that?
When the family decides it's done.
When the family decides it's done, that's right. When in their view the conversation is over, it's over. Other than that, I would agree, it really just should keep going on to the extent you can continue to have that. And then obviously the care for the caregivers here, you can imagine, it's just one of these things to keep thinking about, how horrible the doctors and the nurses are who've taken care of a 3-year-old where this has happened. Think of the doc, the pediatrician who's written the prescription for amoxicillin, second guessing themselves and all that. This is a pretty horrible thing. And then you can practice at your table a little bit. So let's take, again, about 15 minutes. Jen and I will walk around, and then what we're gonna need, and you guys have been so awesome since the first workshop, is we'll need some volunteers to come up and have the conversation with Scott and Sarah. So we'll be kind of teasing that out as well. Any questions on what we're going to do? All right. We can start having your conversation, and we'll come around and give you a hand. All right. So the people from this table over here have agreed that they do not want to be part of that conversation. We're not going to make them do it. Instead, we have 2 folks over here who've agreed to have the conversation. I'm going to have Scott and Sarah come up. As they come up, and again, these are the parents of the 3-year-old, I'm going to need either handheld mics or some mics. Oh, you got them. Oh, God bless you, Kate. You're always on the roll. So why don't you guys, number one, let's give it up for our volunteers. Why don't you introduce who you are and what you do in real life, but then also what the roles that you're going to play up here are going to be. So.
Okay, I'm Michelle Kelly. I come from Buena Vista Regional Medical Center in Storm Lake, and I am the Executive Director of Quality at the hospital there. Mm-hmm. And I'm going to be the quality and safety person in this scenario.
Okay.
My name is Amanda Barline. I am the Chief Nursing Officer at Cass County Hospital in Atlantic, Iowa. I will be the provider today.
Great. Thank you. And obviously from previous conversations, you know Scott and Sarah, you've known them for quite some time, and so you don't have to introduce yourself as being new. And it's a month after Charlie passed away.
Okay. Scott, Sarah, so good to see you guys today. Thank you for coming and being with us. A month has gone by. I'm sure a hard and difficult month for you. We have met before. Doctor, I can't remember your name now. And we've met before. As you might recall, I'm the Quality and Safety Officer here at the hospital. We've had a month now since your poor Charlie died, and I cannot tell you again how sorry I am. It just so sad for all of you, and I can't begin to understand what you've been through. But we thank you today for coming. As you know, before we gathered today, there were some papers that you guys had signed. And so what that does is open up an opportunity for us to have a really open discussion today. What we hope to have come out of today is for you to have an opportunity to talk, to share, to ask questions. We want to give you, to the best of our knowledge today, everything that we know. Those things we don't know, we want to be able to follow up, get the answers, to help you to be able to move forward with all of the events that have happened.
Yeah.
So again, we're very sorry.
Thanks.
At this point, what is your understanding of what happened a month ago?
The headline would be that we brought our son in, he had strep throat, and the next thing we knew, he's dead. And I know it's not that simple, so I guess what we'd like to know is how did this happen?
So Charlie had a condition called Stevens-Johnson syndrome.
Right.
Yeah.
When he was brought to the clinic and he presented like he had strep throat, we took the rapid test. It came back positive. We did send that off for further evaluation, and it did validate that he was positive. As a result of the rapid test, we provided amoxicillin. So your son had never been on antibiotics before, but that is the frontline antibiotic for strep,
Right.
so that was appropriate. What we do need you to know is that the dose of antibiotic that he was prescribed was more than he should have gotten.
Why?
That was a provider order,
Okay.
and it was filled by the pharmacy, and it was carried out that way.
Our normal systems that we have in place to catch a dosage that is incorrect failed us.
So that was a mistake?
We failed. Mhm.
Okay.
We made a mistake, that's right.
Thank you for saying that.
Yeah.
And I did some research on my end, and, you know, the last month has just been unimaginable. And that some children react to amoxicillin. Sorry.
Oh, that's, okay. Do we have
Without,
a doctor?
and you won't know that he could have this reaction, but what can be put in place so that this, like, could they have tested like a smaller dose? Could they, you know what I mean? Thank you. Sorry.
No need to apologize whatsoever.
Couldn't they have tested for that kind of, I mean, he never taken anything like that before, so why don't you check that beforehand?
That's not a standard of care, not a standard of practice. Being that he was antibiotic naive, so he had never had an antibiotic before, that is the standard antibiotic that we start with. It is generally safe. Usually, we prescribe it, and it treats the bug that we're trying to treat, and the child's infection resolves. To test comes with risks as well. It would have slowed the care that we would have been able to provide, but I can understand thoughts, you know, to do that. As a parent, I could ask the same question.
You're telling me that double dose didn't cause
All the research
to
that
die?
surrounds the syndrome that your son had shows that any amount of a medication,
Okay.
whether it's a tiny bit or massive amounts,
Right.
any amount can cause that
You're sure?
reaction. All the research.
With the benefit of the month of time that we've had, we have been able to look into this situation and search the research, and we do know from what we've been able to investigate that the smallest amount of a dose would still have had the same effect. It defies logic, doesn't it?
You know, one thing that we've really been, you know, toiling with was those last couple days for him.
We want to know if he was in pain.
Yeah.
That is certainly a question I would be asking myself. I know you witnessed what Charlie's course was, and the disease, the syndrome is very devastating in the changes to the body. We hope that we were able to provide comfort throughout his time.
But did he feel pain?
We were giving him medication for that.
All right.
Certainly devastating for you.
So we don't know yet.
We can't know for certain that he did not have pain.
So this was a mistake.
This was a mistake.
I mean, are you liable? What is the next steps for us? I mean,
What was a mistake was the amount of the medication that your son got. What may not have been preventable was his reaction to the medication.
what may not have been
Right.
preventable, but could have been? We just don't know?
We may never know. If he was going to react to the penicillin, he would have reacted to any dose. And he reacted, it seems.
Amoxicillin, yeah.
Yes.
It's just been such a stressful time.
I'm sure it has.
I mean, between everything. It's not enough that happens, and then there's just preparing everything at the funeral. It's just, I can't work,
I hope
I
you
can't
never
go
know
to
what
work.
this is like.
We really don't have the words of comfort that you need right now,
No.
but what would be of help to you? Can you
The
describe
answers,
something
I don't know.
that would help?
I don't know. I don't think money would help this, but it is hard to swallow, you know? I don't know.
We're just having a hard time accepting it.
Have
Is
you-
it okay if we need to talk again and we have other questions that we can meet again? I mean,
That is our
I'm not
plan.
thinking straight. She's not thinking straight. It's been a month.
Couple things we can offer you right now. Would it be of benefit for you to have some counseling services?
Yes.
Can we offer that? We are happy to facilitate the scheduling of that, the payment for that. We would like to offer that to
Thank you.
Other things in your life, if you are experiencing other difficulties because of this, we want to know about those. We want to know if there's something we can step in and help take care of for
Thank
you. People in your situation, you know, we can't begin to know what all the losses are. We have funds available. We are not the ones that can actually authorize all that, but we will take it forward and help put you in contact with someone who can visit in more detail.
There's just been so much, and I don't even like to talk about money at this point, but, you know, we thought we were saving for college and how that money is spent on a funeral.
On a funeral.
Yeah. Thank you. We'll think on that.
And we will be in contact. So I know you have my contact information as well as doctors. We want to be here for you in the capacity that you want from us. And so don't hesitate to call, reach out. And like I said, we'll be in contact again with further resources for you to work out a time for some counseling sessions. And
Thank you. Thank you for being understanding.
All right, let's stop there. Oh my God. Wow. Wow. Okay. So could you talk a little bit about, this was actually two tables coming together as well, so thanks for agreeing.
We've met once before.
Yeah.
At the first meeting.
Yeah, no, that's really good. So can you talk a little bit about kind of the questions, you know, that we have? Like, what were your goals? What questions did you anticipate? It looks like you put a plan together, and how do you think you did?
I think we did okay. We missed, how are you doing? We kind of went roundabout there, but to come out and, you know, specifically say, how are you? We kind of skipped to what your
We were going
understanding
to
of
start
this.
stronger with that, and we didn't do as strong as
Right. We talked more to you than allowing you to talk at the beginning of the conversation. So maybe didn't provide enough time for you guys to just say, here is where we are right now. You know, this is, it got there naturally, but we maybe didn't open up with that. I think because there wasn't necessarily negligence that led exactly to the bad outcome here, it was hard not to talk yourself into looking like there was negligence. That was hard for me. I had to like turn it a couple of times as words were coming out of my mouth.
Could you reiterate again what you thought what your goals were? And clearly what she just mentioned were some of them, but what you were kind of thinking you wanted to accomplish?
Hitting the big three. So being honest, showing empathy, and what's going to happen moving forward. What you can expect from us moving forward. And then knowing this was a candor conversation, that ability to ask any question you want and to get the answers, and if we didn't have them, we would make a commitment to come back, look deeper, come back with answers down the road.
How do you think you did? Well, all right, well, let's hear from Scott and Sarah, because you're the ones who...
They will be the better judges of that, so, yeah.
It's always good to internally reflect, though, when we do that.
Well, I think you're being quite hard on yourselves. I thought you did. I thought you started off with a really nice, empathetic manner. You know, I felt like even when she was talking, I looked over and you were engaged in the conversation. You know, which I think is important because sometimes you sort of wonder, like, well, why are you both here? You know, and sometimes you can feel like, well, what's she doing here? I mean, you're just feeling like so. So I thought you both were engaged, even though you were primarily the one, you know, explaining what happened. And Yeah, I mean, I would say I agree with your statement about maybe giving us a little more breathing room to just talk about where we're at and that kind of thing. And I agree. I think the stuff about, the minute you hear, well, it most very likely didn't cause something, I think on our end, we just go, well, what does that mean? Is there still a possibility? And those are just, I don't know how you avoid that, because I understand, it feels like you're speaking a legal sort of language that then in my mind is a red flag, like, why is she saying that,
Cover up.
But I did feel like you provided all of the facts. But I would say to be sort of aware of that kind of language, especially in this situation where everything's confidential anyway. But yeah.
Yeah, I think you
Great.
both did great. I also feel like for two folks who haven't worked together before, I think you guys had a nice kind of listening and respecting each other, and when one of you had an objective, seeing how it went, which was good. I do agree with the talking about stuff a little longer beforehand. I think that also might just help for you guys on your end to know what angle of empathy to take, or what temperature of it, because that's the hard part for you guys, is when you walk into that room, you don't know. You're walking into a question mark. And when you said that you couldn't begin to understand how we felt, I can't tell you how nice that felt.
Yes.
Because I think the first thing you might want to say is, I understand, and that would probably I didn't know how I would feel in this interaction, but it would have been a red button for me if someone said, I understand,
Oh, I know exactly how you
Yeah.
feel.
And
When
just
that's happened before, Scott, the actor will often say, "You've no flipping idea how
Right.
I understand."
Right. And that very well could have
Andy actually
happened.
did do that, and I know you know Andy
Right.
really well in
Yeah.
one of the previous ones. So you're spot on, and what you said was wonderful.
Just a
wonderful.
small body language thing. I would have preferred if you handed me.
Hand
You
us.
sort of, it's
So,
like you're trying to feed.
I wanted like a table, and I hate this setup a little bit because I've had
yeah.
conversations like this. But
Yeah, sure.
I want to be a little bit closer where I can maybe
Yep.
even touch
Yeah.
occasionally. Just like reach out and pat your back or something. It's just a little too far.
In prison, yeah.
Yeah, just it's.
Yeah.
No, it is awkward.
But no, I thought the same
artificial
thing.
as
It
we
was
do
really
that.
bold what you did.
Something.
I really,
Yeah.
yeah.
Great.
You both did really wonderful work.
Awesome. So how about from the audience? Where's our talk box? Where's Kate? Comments, reflections, thoughts? Here we go. Oh. Thanks, Marty.
Hey,
Yeah.
I was just a little curious. You guys reached right to, hey, we can pay you. We've got a fund. And I was curious, is that the route we should go when there's no fault involved? So you've come to the conclusion that there's nothing the organization did. Yeah, they made a little mistake with the med error, the dosage. But despite that, it didn't cause the syndrome which resulted in the death. Is that really where we should go? I think, I'm a little confused.
Well, I'll let Jen answer that question.
And
'cause
by the
that-
way, you guys did a fantastic job. It was
That's
really
the whole
good.
issue around service recovery. That's why we're here. Jen, again, you know the scenario. We talked about it a little bit before. What
Sure.
are your thoughts?
So my hats are off to all of you up there. You did a fabulous job. But I have to agree a little bit. I think there's some degree of service recovery that we would do in this instance. Like when I was up there earlier, I had suggested that MedStar might waive out-of-pocket expenses, which in a conversation like this, they could care less if I'm waiving out-of-pocket expenses, is my guess. And the counseling I thought was excellent. That probably would have been a road I would have gone down meeting with a family like this. After that, I'm not sure. I probably would not have offered compensation. Now, if they raised it, I think in the spirit of this conversation, we can say, we would probably do something to the effect of, well, that's something we can look at, but we have to be honest after exhaustive review. I know it's difficult for you to understand right now, but the care was appropriate, and we just had a tragic outcome. And but that's a very difficult pill for a family to swallow at the time. And I leave the door open to being amenable to discussing it further later on, but I probably would not have offered compensation in that meeting.
Okay.
In all honesty, the counseling part, offering that felt really appropriate.
Right.
I mean,
Yep.
it just felt like, here are these people in obvious need,
Yeah.
and, you know, the
Right.
codependent part of me just is like, oh, give them what they want.
Right.
I think some of the other compensation, if we'd known a little more details about the situation, so like, did they have to travel a distance back to the hospital? Did they have to stay in a hotel to have this conversation? You know,
True.
some of those little
Right.
things, you know, let us take care of those things for you, or, you know, home to the funeral home, or what does that look like? Those kinds of things that don't necessarily, aren't an admission of guilt, but just a gesture of kindness.
I was just going to comment, and I don't know if this is a good suggestion or not, just from my perspective. So I thought the interaction was amazing. You guys did an incredible job. One thing that I have wished for in the healthcare system, and Marty and I have talked about this, is that you want people to understand the patient or them as a whole person. Like in the context of the healthcare system, that's just a sliver of your life. And you want them to understand, you want the healthcare system to understand, I mean, obviously they can't understand everything, but the context in which you come for services. And I just thought it might be an effective lead-in, because we were talking about the lead-in maybe being a little bit more empathetic, would be something like, we didn't know Charlie, you know, could you describe him, tell us what made him so special? And I think that would be like a really healing thing for the parents, just to be able to share with someone else what was special about their child before getting into maybe the details of the event. So considering the whole person is just one notion that I would recommend.
Susan, I love that. In the communication workshop we do, one of the, as you guys may remember, one of the bullet points is just what you said, which is honor that which has been lost, which is to really understand who was that 3-year-old, you know, who meant so much to you and all of that. So I completely agree. That's one of the little prompters we have, and I think it fits into that. Thank you for sharing that. Right up here, Marty, and then any over there.
Well, I
go
hope
ahead.
you haven't covered this in a previous session, when they kind of got to it towards the end of their evaluation, but how is the best setup for this conversation? Is it across the conference room table? Is it in a more casual type setting? I mean, what seems to work best for these kind of conversations?
Well, I actually do like having a small table there to put stuff on. So a glass of water, tissue, and all that, but if it's a small table where we're really close to each other. In other words, I mean, that's my general preference in terms of doing that. Yeah. The other question that came up, really good question, I think it might have been this table, was asking how many people do you send in? And so part of the goal here is to balance the number of family members and who's there with who you have coming in, because you wouldn't have wanted 6 people to come in when there's 2 on the other side. But that's how I have generally found this. I don't know if there's other suggestions. Again, Susan, I don't know in your experience with probably lots of family meetings or what have you, the ideal setup for the room, but I like the idea of a small table there, but not a big table where you feel like you're fully separated from the people that are there.
Briefly, if I can add also, I know that in the pilot program in Southeast Iowa, when they initiate that discussion, they actually ask the patient where they would like to meet, because for a lot of patients, it's difficult for them to return to the scene. They don't want to come back to the clinic. They don't want to park in the same parking lot, to come back through the same hallways. So they actually prefer to have the meeting off-site. So in Dr. McCoy's situation, he always asks them, where do you want to have it? We can come to your living room, we can go to a coffee shop, we can rent a room at a hotel, like whatever is more comfortable for you, to make this a setting that you'll be comfortable with. So I think that all of their conversations have actually occurred at the clinic, because I don't think that any of them have quite been perhaps as significant as this scenario. But that is always an option that's given to the patients before the conversation.
Great. Thank you. Jack. Yep.
First of all, I think you did an excellent job. One trap that you did not fall into is, people have said to me, I know how you feel or I know how difficult it is. And no, you don't. Unless you're sitting in a wheelchair, you don't understand the day-to-day. And if you lost a child, unless you've lost a child, you have no idea the heartache. And you didn't do that, and that was great. As much empathy as you can possibly pour out, I think is good, especially in the loss of a child. But I thought you did a good job there. And as to the second part about where, I was asked, and I said my house. I felt most comfortable there, and Larry and a couple of the attorneys drove out to the house, and we sat down and we spent a couple hours in my house talking to get to know each other. So I definitely think that should be an option of where.
Jack, can you describe what the room setting was like at your house? Because that was like one of the questions, which is what's the geography of the room look like when you did that? And who is kind of sitting where?
Well, there was probably 8 of us. And we had a sofa. 3 people sat on the sofa, and a couple dining room table chairs. I have a recliner I sit in, and sort of in a semicircle type of setup. And everybody kind of went around the room and spoke, and but I could feel from everyone involved the empathy that I think was truly there, and that was the moment when Larry used the word adverse event. So we got that cleared up pretty quick.
I can imagine. Thanks for sharing that, Jack. That's really important. Other comments or questions from the...
Tim, I've got a question.
Go ahead, Marty.
Scott threw out the idea of funeral expenses. And I didn't know where you were going with that, Scott, because you kind of put it in the context of we were saving for his college education and now we're paying for a funeral. So you kind of said, well, we don't need the money because we've already got it saved. But I didn't know how that sounded, if you thought he was fishing for that or how that sounded to you.
Yeah, that's a question for you guys.
I think as he started that financial part of the conversation, it maybe felt a little fishy to start, but it didn't end that way to me. It didn't, that particular statement, I didn't feel like, oh, he's asking for money here. I think he's just saying, this is what my life is now, and it's drastically different than what it was 3 days ago or a month ago or whatever. So it didn't feel like an ask to me.
And Sarah also mentioned, I haven't been able to work. I think that's the word you used them. And that too triggered in my mind, there are implications here to their life that we haven't even begun to consider. You know, you can't work, you know, the comment about saving for college, but now we pay for a funeral. These were all triggers in my mind thinking, you know, there is so much more than just, you know, a death. I mean, there is a whole, you were planning on this life with this child, and now this child is gone. And I have a 3-year-old granddaughter, and so this just tripped in me, you know, it's like, oh my God, what if she died? Yeah.
All right. Thanks. Well, let's give it up for these guys. What an amazing job.
You guys are generous with us, thank you.
Thanks for volunteering. That was really awesome. Really, really great. All right. Where is my slided answer?
It's right here.
Perfect. So I think, Jen, this is going to lead into the conversation about financial and non-financial considerations. When, you know, you've determined care was bad and you need to begin thinking about compensation, because as we know, the next enactment is going to be meeting again with the daughter and son-in-law of the woman who died, and we know there were all kinds of mistakes and things that were there. So Jen's going to lead us through a lot of these considerations, why making an early offer is a wise thing to do in certain circumstances, and Jen, I'll just hand it over to you.
All right. Thank you. All right, so the issue of compensation, again, another hot topic. And it can be very difficult conversations with families, patients. I will say that, interestingly, I'm in Maryland and DC primarily. We've seen a little bit of a, I won't say a total shift because that's too exaggerated, but we are seeing instances of families that do not want to retain counsel for these conversations. They feel, for better or worse, that if they're going to be compensated for an event at one of our facilities, they don't want 40% of that compensation to be given over to a plaintiff's lawyer. So we've had more and more pro se, or people that are unrepresented, reach out to MedStar for compensation, which sometimes, or a lot of times, can make it a little bit more complicated because people don't have a full understanding or appreciation of the process and what's involved in determining what's a fair and reasonable amount of compensation. So I'm going to table that for a minute, and I'll tell you how some of the instances where we have not had counsel and what MedStar has just recently started doing to address those situations. So you have the financial piece, which kind of speaks for itself, although it's complicated, but obviously we're talking about money. We have the non-financial piece, which I know there's been some conversation about with patients and families. Many times when these events happen, one of the takeaways the family wants is the knowledge that the hospital or system is looking at this issue that led up to the event, or issues that led up to the event, and what are they doing so that this doesn't happen again. And many times families will say to me, I really just want to know another family is not going to go through this same thing. So we, in some of our follow-up conversations with families, we let them know what we learned from our review and what actions we are putting into place to try and prevent, and hopefully prevent, this same kind of thing from happening again. We had an event where it was the wife of a resident, actually, that was affected by care. Not severely, although in their lives it was severe at the time. And he was very interested in quality, safety, risk, and he was an active part of our committee or group of key stakeholders that looked at what procedures or what policies could we put in place to try and prevent something like this from happening again. So he was a part of that process. We also have the patient family advisory councils, which I know Marty can speak much more articulately than I can on, but it really is an opportunity not only at the local entities, but with the system for families to get involved because they see our delivery of care much different than we might see our delivery of care. And it's a set of eyes that can really open our eyes as to how our care is being delivered and things that we may not think about that a family is going to be able to tell us. And we've asked for families to help with event reviews. We usually, in all transparency, do it a little bit separately, but sit down with the family. What did you see going on at the time? How did you perceive how things were happening at the time of this event, if they were around? So there are some different pieces to consider. So this, what are the pros and cons of doing, looking at early resolution with these families? Obviously, value-based, it reinforces safety, quality, it reassures our community that we are looking at patient safety and delivery of care very seriously. Consequences for unreasonable care, we will own it and we will compensate accordingly. Clinicians even, I think, appreciate it many times. So, the earlier we can get involved, there's less anger between patients, families, and providers typically. And certainly one of the key things for both families and providers is it's an accelerated process. I mean, as you all know who have been involved with litigation, it can go on for years. And in that interim, the patient and or family is not getting what they need, and there could be real lost opportunities to help these families. So that, and for our providers, I mean, it drags on for them. It interferes with their lives as well in a different way, but it's a way to get things expedited and resolved as quickly as possible for everyone involved, but primarily our patients and family. So the downside, we probably have overpaid on some claims in an effort to resolve. I don't think exorbitantly, but I'm sure we can think of times that we probably compensate a little above where we normally might value that injury. And then, of course, which a lot of people, when they hear this, they're like, you're just asking for claims to come in. Maybe these families don't know that there were opportunities missed, and yet you're going to go up to them and say, oh, we'd like to meet with you to go over these things we identified that could have gone better in the delivery of your care. Staff, again, I am privileged in that I typically don't have too much of a problem in terms of alienation of staff. I think as we've talked about before with MedStar, it's from the very top that has trickled down, and it is our culture. Typically, there's not a lot of resistance. I mean, there are people that are nervous, certainly, I won't take that away, but willing to work with us, to work with these families. And of course, even aside from plaintiffs' lawyers, defense lawyers, I mean, when I practiced, it was deny and defend. That's what we did. We will find someone to defend this care. This is what we're going to do. We're going to get it all lined up. Now we ask our defense lawyers, we don't want an expert that's just going to say everything was great. We need objective external reviews. We want to know strengths and weaknesses of where we are, help us evaluate our case. And plaintiffs' lawyers, also, I will comment for just a second on plaintiffs' lawyers. As Jack alluded to, we've had a very difficult time with the Maryland legislation in terms of getting Candor statutes or laws passed. MedStar is, I will say, getting a reputation in our demographic area. Plaintiffs' lawyers know that we are transparent and try to work with families directly. Sometimes that's very helpful. I mean, they know they take some of the anger out of our relationship with these families. It's recognized. I just went to a mediation 2 days ago, and the plaintiff's lawyer joked around with me that my name was everywhere, all over this on papers, because we had helped with living expenses and helped with car payments and things. And again, it did not, in the end, avoid a claim, but we came to the table as amicably as possible, and were able to reach a resolution. So I think they know our intent is good. It's probably a little threatening to them that we are, able to work with these families. And again, as I was saying, I don't know whether our reputation precedes us, but I seem to notice a slight increase with the number of patients that are electing not to even have a lawyer present, which in a big, quote unquote, big case, I would not recommend. I mean, I think there's no question a family with damages that are high, and they do need representation, so I'm not advocating for them not to have a lawyer. In fact, many times I encourage them to have a lawyer to help with the next piece, which is identifying what is a reasonable amount of compensation for these families. So at MedStar, who really talks about money and what we're going to do? So I will say we do pretty well operating as a team and understanding our various roles and positions within MedStar. I alluded to it a little bit earlier. Local risk managers at the entity do have some authority there to act in real time if for some reason they can't get us, for like a hotel, things like that. We also have, we encourage not only our risk staff, but also our patient advocacy staff to talk to families, see if they can identify what their needs are at this time. And all local entities have the authority to place all bills on hold pending review. And I will say that process at MedStar has really tightened up. We're much better at it. As soon as we hear of a potential event, and I'm sorry, Jack, to keep saying that word, they just email our billing office and say, put the bills on hold for Mary Smith pending risk review. So that is done pretty robotically at this point in time. We really have gotten much better. Now, our problem where we need to get better is then remembering to go back to billing and give them a disposition on what to do with these bills. Sometimes we're not so good at that. Again, patient advocacy or risk, or sometimes myself, because I handle a lot of hospitals, and speaking to your end, if something happens at a smaller community hospital, MedStar is a large health system with 10 hospitals. They're typically transferred to a higher level of care within MedStar. And I handle Georgetown. So if they go to Georgetown, I will try and go to meet with the family while the patient is at Georgetown to introduce myself and be a point person. Again, reassuring them that it's been escalated, the care is being reviewed, and that we need some time to review the care, but our end goal is to get back to them and meet with them and try and answer all their questions. So once the event review is done, then we reach out to the family, ask them if they would come in or wherever they would like to meet. Providers are there, typically patient advocacy, especially if they've built a rapport with the patient and family, they will be present. And then I would be present in case the issue of compensation comes up directly at that meeting. I do explain who I am. I've got a business card that is claims manager and RNJD after it, so sometimes people don't like seeing that on the business card, and they're like, oh, you're the hospital attorney and you're here, to defend the hospital. And my answer is that I am not the hospital attorney, that I work in our risk management office, and my role here today is to be a part of this conversation. If there's something MedStar can do right now to help alleviate some of the stress for your family, I'm one of the persons that can try and work to make that happen. And in the event compensation is warranted, I'm one of the contact people that can help make that happen, whether they have a lawyer or not. I'll say most of our conversations, a lawyer is not present, not for MedStar and not for the family. Now, having said that, if the family wants to bring a lawyer, that would be fine with me. We certainly would welcome it. But most of my experience, I've only had one meeting where a lawyer has accompanied the family.
Jen, on the issue around the bills,
yes,
I'm just wondering how you've hardwired that, because that is a complicated thing. I can tell you at U of I, we did, many of you guys I think heard this at the previous couple workshops, we did a wrong-sided neurosurgery case. And we didn't hold the professional fees. In other words, we got the hospital covered because we're pretty good at the hospital level. We're not all that good at making sure we had the physicians group, so the pro fees went out. And of course, when they didn't pay, we sent them to collections.
Right.
So I'm just wondering how you guys think about that, or any of the others here who've cracked that nut, because this is a really, patients hate it. Jack, as you probably know, when our care is bad and they know it, and we bill them and send them to collections. And Susan, that's
right.
You may want to be able to comment on that too as well. But boy, that was like salt in the wound
right.
when we did this, and it's such an important piece that a lot of people in this room might be part of. So how do you hardwire that for both the pro fees and the hospital?
So practice is one, one of my answers. We worked directly, again, with our risk management. We have monthly meetings where it's all of risk management comes with claims up to corporate, and we talk about pertinent risk issues, and billing really seemed to take a precedent because we were not great at it at first, or we would hold one bill and forget to hold the next. So we met with billing, we tried to simplify it because like anything, the simpler it is, the easier it is. We identified 3 persons within billing. We had a hospital biller, a professional service biller, and radiology, because then inevitably radiology bills started leaking out, even though we held everything else. So we just have those 3 contact persons, and it's automatic. And I will say sometimes we're very duplicative. The local risk office may send it, and then my office may send it as well, just to be on the safe side as soon as we hear. Yeah. Now, getting back to the independent practitioner, I cannot put an independent practitioner's bills on hold, and that always is difficult. We can tell the family we're putting the hospital bills on hold while we review. The physician piece, again, I kind of stumbled because it is a challenge, and I explained to them I can't control the billing from the physician piece when that happens. But in the end, at the end of the day, MedStar has paid professional bills of non-MedStar physicians to help families at the end. So their responsibility, the family's responsibility. So we have done that on a couple of occasions, well, actually multiple occasions, so that the family's not held responsible for that bill.
One of the things we did is, and this comes up as well, is what if you have a harm event that's going to require ongoing care? And one of the biggest cases we had was a big fire in the operating room. And we knew this patient was going to need at least 3 or 4 other surgeries and then a multitude of office visits. So what we had created, our head of safety and risk management created a little card that was called the Patient Safety Compensation Card. And it would be given to the family when we were admitting liability and saying, hey, we own this, we shouldn't have caused this fire. You need to use this card as your insurance card every time you come back to our hospital, and we will be the guarantor, not your insurance company, for this care that you're going to get. And it was amazing because then they stayed with us, and that allowed us to control our costs and allowed us to create a really neat database to begin to do that. And that was just one of the things. We had no other way to do it when they would want to come back and set that up. Yep. Oh my God, Marty. So here it is. Here's an example right here. We burned Marty, in the operating room. He's recovered really well, as you can see. But this is it. And they would present it, and then automatically we had medical record numbers that billing had to say, yep, that is one of our patients. They're not coming in for care they shouldn't otherwise be entitled to for free, but it's related to that. It was a really neat way to track what we were doing.
That's a great, we are not that organized, in all honesty, but we have improved tremendously. And again, I know I sound like a broken record. I'm lucky I work with a healthcare system that covers a different acuity of care. So we have the community hospitals, and we have our higher level hospitals. We have rehab hospitals. So we can control the billing within our own system. And so for an example, if there's an event at a community hospital and then that patient is transferred up to Georgetown for care, we automatically tell Georgetown, you've got to hold those bills pending review. Same for rehab. If somebody needs to go to rehab, then we will tell them, you've got to hold those bills. So we are lucky on that. We're better with the follow-up appointments. Best examples, outpatient physical therapy, occupational therapy. Again, those we can provide within our own healthcare system, and we can, my office can put a hold or tell people we're waiving those costs. So that does make it easier. I would say that we have had some misses where patients have shown up for follow-up care or subsequent treatment, and those bills were not put on hold. And when that happens, the patients and families are not happy, but I will tell you that most of the time, by the time we're there, we've already have the rapport with that family, and they know to call me, and I tell them, and I always tell families when I let them know if we're waiving these bills, if you should receive a bill in error, just send it right to me, and I can intervene on your behalf, so that they're prepared without hopefully making them too angry if they should receive some kind of bill at the time. And if I know they're coming back and know when they're coming back, I can tell the clinic, like if they're following up in ortho, I can say, do not charge this patient when they show up. So we're better at it than we were, but the follow-up care is challenging. But I think we are doing better on that. But I like your idea of the card. So damages is always a tough conversation. It's usually uncomfortable. There's no amount of money in the world I could offer that family that just lost their 3-year-old that's going to make everything okay. And there's no way any amount of money, is going to make a person completely whole after a catastrophic event. It's helpful for them to help them get through, but it's not going to solve the whole problem. So one of the biggest challenges in that regard is how to work with patients and families to manage their expectations. And this is very, very difficult. It takes usually a lot of time. I've had people telling me, they want $5 million because there was a small thermal burn during the course of surgery. And somehow you have to be comfortable that you've gotten to know this patient and family to help them understand why we realize you had an injury. We want to work with you to reach a fair and equitable resolution. And I've come right out and said, MedStar does not value this case at $5 million. So we need to find a place where we can start in terms of any kind of negotiations. Now, this is where lawyers can be helpful. Some plaintiffs' lawyers are better than others at managing clients' expectations. But these patients and families aren't going to trust me to say, that's not worth X amount of money. I mean, I'm here on behalf of the hospital. They're skeptical. I just don't want to pay out. So it really, it can be difficult. And I think it just takes a lot of patience and a lot of time to be able to help these families either through counsel or on their own. And this is where I'm going to go off the slides for just a minute. So very recently, we have had 2 families that were not represented by counsel and did not want counsel, despite our recommendation to get counsel. It was not high damages, millions of dollars, but it's still, they were seeking a significant amount of money. And we did not value the case at the same place that they did, and we were on opposite ends of the spectrum. So interestingly, we made an offer to a family to mediate, again, encouraging them to get counsel, but explaining that a mediation process would get an objective third party involved to help evaluate this claim and try and reach a resolution. So we've done it twice. The role of the mediator, as you all know, is to make sure it's fair and equitable. So if anybody challenged it, which they could or try to, this person would be able to say they were not there on behalf of MedStar, they were not there on behalf of the family, they were the objective party, and it was a fair and equitable resolution. So it was an interesting process without counsel. We didn't have counsel either. It was just me, honestly. In both these instances, I did not bring counsel. There was no, I would not have been comfortable bringing, my defense counsel with this family that did not have any counsel. So it was just me, the mediator, and the family trying to work out a resolution. And I will say in both instances, we were able to do so after a few hours of working with the families. You know, you just need to stress with families. That's a very new way to go. I don't know if any other health systems have attempted anything like that. You just don't want a family to be pressured into feeling that they need to agree to a certain settlement. And, you know, while we're talking about that, the other thing that patients need to realize and families is that while we provide some service recovery and do not require a release at the time, once we reach a settlement, there is a release. And it's important that they understand the ramifications of that release, that, you know, they get one bite of the apple, so to speak, and that this is settling it in full forever. This is it. So people really need to have a very clear understanding that that's what's happening. I've had one family where they were insistent on settling with MedStar, and I kept telling them that this was too early to settle with MedStar. You were not finished with treatment yet. You're not, you know, the outcome, you want to wait. But they were adamant about settling, and so they did get a lawyer and they did settle. But I always felt, you know, I wish they had waited a little bit longer. Not because I thought, you know, you just hate for something to get exacerbated and then they don't have an opportunity to come back. So timing is everything with these things. So we kind of touched on this a little bit. What do we reimburse for? What do we waive? What about lost wages? Pain and suffering is probably the hardest piece. And again, takes sometimes the skill of a mediator. I don't know that we discount our number because it's a settlement. I mean, I think ultimately your number is discounted because you're not incurring the legal expenses that you would if you were bringing something all the way to trial. But I'm not sure that we discount our number ahead of time. Certainly medical bills for that are at the event that took place and then at the subsequent care, those are, depending on the circumstances, waived. Lost wages, we certainly have, you know, obviously have paid out for lost wages. We typically will, without being defensive on that note, we'll try and get some kind of documentation or support from, or to supplement or to support the patient and family's claim that they earn X amount of money and they were out for X amount of time. Loss of consortium, again, that's difficult. I think it just takes you know, a reasonable person, which is not always your client or your patient. And so again, just time and patience. And I am a believer in that when these kind of numbers are up there, that it is better to have counsel involved for everyone's purposes. I do tell families I can't make up the number that they should be asking for in terms of compensation. That's something that they need to discuss among themselves, come up with what they feel is a fair and reasonable number. And again, we typically will ask patients or families to provide some kind of documentation to support their request or the amount of their request for compensation. So, as in everything with this whole process, communication is key. Set the expectations early. Families often think if there's no lawyer involved, it's going to happen in a matter of a week or 2 weeks. So you want to set their expectations clearly so that they know what's involved. I always tell patients and families it is a process. And it takes time. I'm not the only person that makes decisions in terms of compensation. You know, we have a whole way at MedStar between reviews and, I don't use Larry's name per se, but in talking about where we could value this case. The other piece is liens. I don't know how many of you all have dealt with this. It's a complicating factor, the super liens. For lay persons, that's a tough nut to crack. They don't understand it. And that is a process in and of itself. And I have helped pro se people with that in terms of putting Medicare on notice that a claim is being filed. And I just explain that, you know, it is a process. It takes time. We have to wait for Medicare to come back with their conditional payment because that would be a part of our settlement discussions with these families. And again, the release, they need to be aware that a release is required. And again, all of this, by the time you're at this point, hopefully you do have a decent and open line of communication with patients and their families, which helps make this a little bit easier. We try and work to resolve cases as soon as we can, once we have made the determination that that is what we want to do. Again, it doesn't happen in a matter of a couple of weeks. It usually, I would say, on average, takes 30 to 60 days at best. But if you make that clear to patients and families, that is helpful. You won't have somebody calling you every couple of days. Have you made a decision on what you're going to do? So lay out the groundwork of how it works. I always tell people I'm open to questions anytime they want to call me or think of things that they want me to consider in this process. I just try to leave the lines of communication open, and that usually helps, again, with this process. So again, even from the beginning, you know, the patients and their families will work with you. They can help identify what their needs are. I think the biggest thing is fear of the unknown, fear of the financial implications of what this event will mean to their family. Have open dialogue with them. What did happen as a result of this care? Were you out of work? How long were you out of work for? What did that mean? Did family have to travel in? Hotel expenses? Anything really, just to get a big picture sense of the impact for this family financially. Again, we could look at out-of-pocket expenses. What about other people in the family? Did they take off work? Now, in some instances, before we even get here, we have actually already provided home care to help with some of these things before we even get to this piece. But you want to have a very clear understanding of what the impact was for this family. I think we've touched on this quite a bit, but we've paid, again, MedStar waiving bills. On occasion, when patients have, MedStar has some urgent care centers, and unfortunately, we've had occasions where patients have left urgent care centers and then had to go to another emergency room, whether they go on their own or by ambulance. So we have offered to pay outside vendors to cover costs if it was a result of the care that they received with a MedStar facility. I have found actually that most vendors are agreeable to that. I mean, most of the time I will call if the patient sends me the bill, for example, for EMS, and it's $500, I can call EMS and say, you know, this is MedStar, we're covering this. Can you send me your W-9? I want it to be noted that MedStar's covering this bill on their behalf, and I've never run into a problem with other vendors not being receptive to that. Certainly, as we discussed, ongoing treatment, physical therapy, certainly meal cards, hotels, like your example of the pet sitting. We've provided a nanny service for a woman that had just given birth and had an infection after a C-section, and her husband had to get back to work, and she was home, no family support, home alone, so we provided a nanny service to come in. And we had her pick out the service. Obviously, that's not under MedStar's purview, but obviously we wanted her to be comfortable with who came into her home, so we had her make that decision, and then we worked with that agency to provide care. So you can be very creative to address people's needs, and people usually aren't too shy about asking for what they think they need. Again, the non-financial, certainly, I think sometimes it doesn't always solve the problem, but it's certainly providing, transparent information, being open and honest with our patients and families is part of the resolution process. Empathy, as we just witnessed with this enactment, none of us would know really what that family is going through. And I think you need to convey that you don't know what they're going through, but do so in just an empathetic manner. Sometimes I've had people ask for plaques there, and I think Georgetown at one point someone was asking about a scholarship for the university with a patient event. Again, invitation to join and improve our delivery of care, such as the patient family advisory councils. And as I stated at the beginning, the commitment of our hospital and health system to improve our services and put into place action items. And I will say, I've also told families that, let's say an event happens at Georgetown, certainly with a system, I want them to know that if it's a service line that is also offered at other hospitals, that we use it across the system so that we can prevent it not only happening at Georgetown again, but from happening at one of our other entities down the street, so that it's more system issue and system fix as opposed to just being isolated to one of our hospitals.
So Marty, want to comment on some of those? Because I know you've talked to a bunch of patient advocates about, can you go back one slide to some of the elements to that that we're learning more and more are really important to patients and families?
Yeah. Well, on this slide, I would say that I'm always surprised when someone brings up something that's important to them. It's a little bit like getting to know the whole person, as Susan was saying. There are things that are very non-financial that are really part of wanting to remember somebody who's passed or wanting to ensure that there's a meaning to this all. And other points that you were talking about, Jen, I think, and actually Kate, who's over here having a sidebar conversation. Sorry, Kate, I'm going to drag you into this. I've been in mediations where, kind of the pain and suffering piece is discussed in context with what you have to pay your own attorney. And I know you were talking about actually talking to plaintiffs' attorneys about an hourly fee. And I don't know how much that plays, if that's actually happening now or if that happens in the mediation process, but that kind of, I think as a patient or a family member, we don't have a lot of experience, the average person on the street, in figuring out how to negotiate a contingency fee with a plaintiff's attorney and how to make that work. And I'd worry a little bit about that being a surprise. Kate, do you want to respond to that?
Sure,
yeah.
I would not be able to catch this. So we have talked to a lot of plaintiffs' attorneys about the possibility of them switching to an hourly rate as opposed to taking 35% of the total recovery, which makes sense. You might want to get 35% if you spend 6 years fronting costs and proceeding to litigation, ultimately taking a trial, having a trial. But if you represent a patient for 6 weeks, 6 months, maybe a year, in a pretty non-adversarial setting, then it doesn't make sense to get more than a third of the total recovery. So my response in reaching out to plaintiffs' attorneys has been tepid. I'm working on it. I have gotten plaintiffs' attorneys who will agree to take less of a percentage, which is a step in the right direction, but 20% of a large recovery still seems like a lot for maybe a total of 20 hours worth of work. So as plaintiffs' attorneys are getting more experience in this and they're learning how little work it actually is to reach a resolution, they're becoming more open to it. So I don't have any firm commitments from attorneys at this point to say, yes, I'll take this at a standard $150 an hour instead of taking 35% of a $100,000 recovery. But I think that we will get there as they become more familiar with the process and really do see, I don't have to put nearly as much work into this. I don't have to pay court reporters. I don't have to pay medical record fees. I don't have to put forward any expenses before I actually get paid. So the short answer is no, but we're working on it.
Yeah.
What I'd say about that is, because I've coached a couple of families to go through mediation, and I've seen the judge actually create the expectation. If you want them, so in the going back and forth to the different rooms, let's trade the pieces of paper, I've seen the judge say, actually, I expect you, plaintiff's attorney, to reduce your fee to this amount. And maybe that will take time. I think, Tim, you also saw in Illinois that as people saw the Candor process, 7 pillars it was called then, play out, that you had plaintiff's attorneys who were willing to step up and say, you know what, I'd work with you a little bit on this. You had like a cadre of people that you could recommend the way they're doing here in Iowa.
Right. So we weren't recommending one person. We'd say, here's a big list of plaintiffs' attorneys we can work with, and we have worked with. If you go outside this, can't guarantee anything, and that was very helpful to have them to work. And Marty, I'd like to reiterate what you said about, as Susan said, the real goal is trying to find out who this person was, what they meant to you, so that whatever you do is super meaningful. I can tell you that in the ear embolism case, there was a real case in Chicago, and you can Google this and look it up. It happened around the time of ours, involving a guy named James Tyree, Tyree. He was essentially the chairman of the board that owned the Sun-Times. He had a large dialysis catheter in, and it was pulled out by an intern when he was sitting up. Sucked in air, and he died. And here, he was a member of the board of the University of Chicago, and it happened at the University of Chicago. So his settlement, $5 million of it went into a foundation that was called the James Tyree Foundation, all dedicated to education on the south side of Chicago. That's what meant so much to him to do that. It was a great wake-up story for us to say it's getting to know who the whole person was. And he was such a huge benefactor, it meant a lot to him.
The other thing that I've seen that we might add as a bullet here, because I've seen it more than once, is a commitment to talk about this. So the plaintiff or the family will say, I want you to tell other people what you've learned, because they figure out, this just doesn't just happen here. It happens elsewhere too. And then that becomes a way to kind of also hold the hospital accountable for walking the talk. You say you care, you say you want to prevent, are you going to talk about it with other people? And I've seen that, I want to say 4 or 5 times where people just spontaneously come up with that. The other thing I was intrigued about with the role play is the offer of funeral expenses. So that was a non-breach of standard of care case, a non-liability case, but it was the case I'm thinking about at one of the 7-pillared pilot sites where there was a man who died, and he was a veteran, and it was really important to the family to give him the funeral of a veteran with the salute. And that came out in the conversation, and the risk manager walked into the CEO's office and said, this is what's important to this family, and the CEO said, here's a check to make that happen. So I think that was that kind of goes to your point, Susan, just about what is important to this family.
I agree.
And I will say that there's been a couple of occasions where MedStar has covered just that, like funeral expenses for families.
No, it's a quantifiable thing. You can kind of figure out how much it costs, and yet it's a really, really meaningful gesture, I think, and going to the funeral. I mean, having people go to the funeral, I think we've also heard people talk about how important that was. It's just a sign of respect again. Okay.
This is actually for Dennis. I'm just the courier here.
Thank you. And one more point, not to belabor the fact about the plaintiff attorneys here in Iowa. While we do have a few folks that have now been involved with the West Burlington pilot project and are gaining expertise, and Kate is working through the rest of the plaintiff bar and educating them about this and trying to get them to be open to new models of payment. It's important to note that as you're encountering these cases and considering all of this, the Iowa Association for Justice the membership organization for trial attorneys, helped write this statute. They were there, they were 100% on board with this statute. So if you're encountering folks on the plaintiff bar that don't know anything about this model, Iowa's law, or folks that do have trepidation, encourage them to go back to their own professional organization. Those folks have done outreach to Massachusetts and Oregon, the other two states that were before us with this statute. They are believers in this concept, and they can be a really good resource of educating folks that external of asking them to trust all of us that normally they would be on the other side of the fence from. They can ask their own peers, and they can learn from their own peers and grow in that respect.
That's very interesting, because we, as Jack said earlier, Maryland, we just can't seem to get by them at all, which is frustrating, obviously.
We're going to have to take him out for drinks sometime.
I know.
A couple Irish guys, yeah, and then we'll get it moving. So, thanks, Jen.
Sure. I will say, with our plaintiffs' counsel and mediations, I will say I've not heard any talk in terms of the hourly rates. I will say that at times they have reduced their fee to, from 40%, I'm going to say 30%, in an effort to get the case resolved. But that's really about, sadly, the extent of it at this point.
Great. Thanks, Jen. Well, let's take a break, 15 minutes. What time should they be back? All right, 2:55. And we will hit the home stretch, and we'll be looking forward to the last interesting enactment and debrief.
This Candor project